Think about this. Your child wakes up tired, loses focus by mid-morning, spirals emotionally by lunch, and everyone's telling you it's ADHD. But no one's checking what happens during the 8 hours their body's supposed to be healing, sleeping. What if that's where the real damage is happening and no one's talking about?
The establishment of nasal breathing or the reestablishment of nasal breathing. The child will go from having nightmares to having sweet dreams. So night terrors is not normal. And so that's another sign of obstructive sleep apnea. So the restoration of normal dreaming, breathing, deep sleep, the nasal breathing we've talked about, and just a certain calmness will come over that child. The child will be more responsive to parental, commands and parental discipline and that sort of thing.
Welcome to the Soaring Child Podcast, where parents of children with ADHD learn tips and tricks to help their child soar at home, at school, and in life. We feature interviews with experts, medical professionals, and parents just like you who are learning how to reduce ADHD symptoms using food and other natural strategies. Because children with ADHD deserve to soar just like every other child. I'm Dana Kay, your host. Hello parents, this is Dana Kay here with another edition of the Soaring Child Podcast. I remember speaking to a mum who said her son had been diagnosed with ADHD and was on multiple medications. It's a common story that we hear often, including my own son, which we all know about. Yet this son of hers had woken up exhausted every single day, melted down every mid-morning, and really still struggled to focus. Something felt like, was missing, and she was definitely right. What if some ADHD symptoms aren't actually ADHD at all? Today's episode explores something many parents haven't considered: pediatric sleep apnea. It's far more common than most people think, and it can mimic symptoms like inattention, mood swings, behavioral struggles. So to help us unpack this topic, I am super excited to bring on Kirk Huntsman. Excuse me. Sorry about that.
All right.
Made a mistake. Huntsman. Like the spider.
There you go. Give
me one sec.
I appreciate you doing that. That actually is going to make me feel better when I mess up a little bit. So.
Sometimes I fly through without anything. Sometimes, you get caught, but it's good that you've got the editing. So
there you go.
To help us unpack this topic, I'm joined by Kirk Huntsman. He is the co-founder and the CEO of Vivos, a pioneer in pediatric oral health innovation. He has decades of leadership in the dental industry, and Kirk is here to share how undiagnosed sleep apnea may be one of the root causes of what looks like ADHD and what parents can actually do about it. So if your child has been diagnosed with ADHD but still isn't thriving, this is one conversation you need to hear. Kirk, welcome to the show.
Oh, thank you, Dan. I'm just so thrilled to be here. I can't even tell you. This is such an important message. And parents, they're on this quest to figure out what's wrong with their child, and nobody talks about this. And so I'm just thrilled to be here with you, and I think you're doing a marvelous work.
Thank you very much. We're excited to have you. Definitely a topic that's close to our hearts in, what many doctors and people are not talking about. And so, obviously a lot of our listeners, they do have children that have ADHD. And a lot of people have heard of ADHD, even if they don't have a child diagnosed with it, but far fewer know about pediatric sleep apnea. So can you explain to listeners, what is it and how can it mirror ADHD symptoms?
Oh, that's very, that's a great question to start with. So let's just start with the idea that ADHD is a diagnosis that's predicated upon a series of observable symptoms in the child, right? So the child presents with A, B, C, D, and E, and the clinician who's looking at that child says, that is ADHD. Now, every child may have some of the symptoms, but not all. And so every child presents with a little bit different profile. But when you look at a cohort of kids with obstructive sleep apnea or a sleep and breathing disorder, you look at the symptoms of how those children respond to that sleep and breathing disorder, and they match across the board with the kids that have a neurobehavioral problem such as ADHD. And you look at these sleep challenged children that have OSA or some other sleep impediment, and what you find immediately is that there's a huge overlap of the symptoms. And so they've actually taken kids known to have ADHD, and they've put them in a playground with kids known to have sleep and breathing disorders, and they put physicians, clinicians behind a wall, experts, and they said, identify the children that have ADHD and the children that have sleep apnea, and they can't do it. They can't do it. There's that much overlap. And so it's really important for parents to understand that they have to ask the right questions of the clinicians to make sure that an assessment of a child's sleep and breathing patterns and sleep and breathing capabilities and habits and that sort of thing is part of the overarching diagnosis. Because otherwise, as you mentioned, these children are going to get labeled as ADHD, typically a behavioral problem. That child, right, in the classroom who can't sit still, who can't keep up because and falls asleep in class, does all these things. And they're going to get referred to the school nurse, who's going to refer it to the pediatrician and the parents to get that child on some type of psychotropic drug. Mm-hmm. And all the while, it's not a neurobehavioral problem. It's a symptom of something else that's going on that gets misdiagnosed. And so that's where we are today, actually.
Yeah. And I love that the way that you explained it. And you know what's fascinating and what a lot of people don't talk about is that ADHD is actually meant to be a diagnosis of exclusion, meaning that your doctor is meant to exclude out everything else it could be before diagnosing ADHD. And so this is a classic example where it never happens.
Right.
And all of the things that we teach and preach on this podcast and share with listeners is about looking at all the other factors that could be contributing to those symptoms. So I absolutely loved the way that you explained that. Now, what are some of those key sort of warning signs, like either, in the daytime or the nighttime, that could maybe indicate, a child's focus issues aren't actually sleep related?
Okay. So one of the things we have to understand first and foremost about when we're talking about pediatric OSA is that kids respond differently than adults to the OSA condition.
Can you just, for listeners, explain what is OSA?
Oh, OSA is obstructive sleep apnea.
Okay, thank you.
Obstructive sleep apnea, let's talk about what an apnea is, first of all. An apnea is when the airway closes down and the child or the adult, an apnea event can happen in either child, a child or an adult, but it's when the airway is shut and so that there's no ability to breathe in. And that can happen, that has to register as an event, it has to take place for at least 10 seconds. Mm-hmm. Now, in an adult with sleep apnea is diagnosed as having sleep apnea if they have an apnea event, let's say once every or less than 5 times an hour, right? That's if they have it 5 or more times, it's actually sleep apnea. Now, if they have 30 times an hour, it's severe. Okay, so somewhere along a spectrum, an adult will present with sleep apnea. But the demarcation for the occurrence of sleep apnea is just 1 event an hour per kid for a kid, or severe sleep apnea. I want to say I didn't check into this stat before I came on the air here, but I want to say it's 5 or maybe 10. It's a much lower threshold of these apnea. They're called apnea hypopnea events for a child to be diagnosed with a very severe condition. And so what happens is sometimes there's hypoxia associated with these apnea events, which is a blood oxygen desaturation, which means the child or the adult with this hypoxia is not getting enough blood oxygen. Sometimes there's other kinds of things that are happening when a child or an adult stops breathing. So sleep apnea is known to be comorbid with all kinds of really chronic disease conditions. In adults, it can be cancer, it can be diabetes, it can be fibromyalgia, it can be Alzheimer's disease, dementia, depression, anxiety. In children, they go the opposite direction. When a child is deprived of sleep, primarily because these apnea events create arousals and what's known as periodicity, right? So it's actually interruptions to the sleep, fragmentation of the sleep over time that prevents that child from getting into REM sleep, where they really get the deep rejuvenation that they need to restore and rejuvenate. Now, a child responds in a way that they, rather than becoming excessively sleepy in the daytime, which is what an adult does, the child becomes hyperactive. Yep. And so a child that becomes hyperactive shows up at school and becomes that kid, right? That the teacher can't control. They're in everybody else's stuff. They're causing fights on the playground. They're doing all the things that kid does. And immediately they get identified and labeled as a problem child, when the real problem is that child's not sleeping well. Mm-hmm. And they're not sleeping well because they're not breathing well. And so when we dial this all back, it comes down to we were designed as human beings to be obligate nasal breathers. Now, I'm sitting here and I'm looking at you and your mouth is closed and you're breathing through your nose. That's the way you were designed to breathe. That's the way I was designed to breathe. And so we were designed to be obligate nasal breathers. So the first sign of this type of condition in a child is when the parent observes that their child is mouth breathing, whether it's at night or during the day. Mouth breathing is typically that's one of the early signals that there's a problem. Now we can go through a list, and I'll go through in the course of this podcast, I'll go through some of the other ones, but the presence of mouth breathing, even when the child just walks around with their mouth open, right? So, you and I are looking at each other here and I'm talking, so my mouth's moving, but you're sitting there breathing through your nose. And that's where the child, when the parent needs to observe their child in a natural state while they're watching television, while they're doing whatever. And is that child breathing through their nose or are they breathing through their mouth? If they're breathing through their mouth, that's what gives rise to the inflamed tonsillar tissues, the adenoid tissues. And that's why what the go-to strategy has been from a medical profession is, well, let's cut those things out. Let's take the tonsils and let's get them out of there. Let's get the adenoids out of there. And what's been found is that while there might be some temporary alleviation of those symptoms, it doesn't last. And so what's really needed is a redevelopment, and I can talk about this, about where this all stems from, but a redevelopment of that child's airway. And that's what my company does, really, is we provide clinicians with the tools to non-surgically redevelop or guide the growth and development of a child's airway so that it's big, it's open, it's patent, and it functions the way it's intended to function.
That's fascinating. I didn't share this, but my son was diagnosed with sleep apnea back in the day. Classic, he would sleepwalk, he would sleep talk, he would sleep with his mouth open. Didn't know it back then. He was that problem child. He did get diagnosed with ADHD. For him, it wasn't just the most underlying root cause of the whole ADHD, but with everything else that we've done, no longer is suffering. But we went down the path. He had the operation, and if I had known a less invasive process back then, it would have been, fantastic. And I will say, like, when you have operations, that also adds to inflammation
It
because,
does.
you're
Totally.
bringing in all that toxic medication from the operation. You're taking out something that's meant to be there in the body. And so I love what you're doing. Okay, so we've talked about classic first, mouth open during the day, mouth open during the night. What other some other indications that they may be suffering from sleep apnea?
Well, so you want to, as a parent, you want to observe the child while they're sleeping. You want to see, is there snoring?
Mm-hmm.
Is there excessive snoring? Is it, there's, every human has times and moments when they snore a little bit. Now, women purr and men snore, right? So it's just to get that correct, be a little politically correct here, but it's actually children will have varying degrees of snoring as well. That's another sign and signal. Now, that doesn't automatically mean that your child has sleep apnea, but if a child is snoring, that means that there's probably some type of an obstruction going on
Mm-hmm.
that is preventing that child from breathing optimally. Okay,
Mm-hmm.
so breathing should be silent. Breathing should be consistent. Breathing should be clear and unobstructed. And so parents need to look for and listen to see how their children are breathing. It should be nasal breathing, silent, quiet, consistent, and it should not be prone to loud things or gas or intermittent where they stop breathing for a while and then start up again. So these are all things for parents to kind of look for. In terms of some of the other signs and symptoms of pediatric sleep apnea, a child will actually exhibit, and this is where sort of the neurobehavioral things start to come into play, but they'll actually exhibit certain kinds of behavioral, let's just call them behavioral anomalies.
Mm-hmm.
What the parent sees is, my kid is a problem. My kid won't listen. My kid won't obey. My kid won't follow through on things. My kid, I don't know what's going on. I'm a good parent. I've got three other kids that are all, towing the line, but this one is just completely off the rails, and I'm doing the same kind of parenting. Well, it's not you. I just want to tell the parents out there, it's not you. It may well be that your child has a developmental deficiency. So we can talk a little bit about where this comes from, because this actually begins in the womb. And it begins with the nutrition of the mother and the way that the embryo and the fetus develop inside the mother. And actually, during the birth process, depending on how that birth process goes, if it's a protracted birth process or if it needs to be aided by forceps or other things, it can oftentimes create craniofacial anomalies where you've got the retruded mandible. You've got and one of the ways to look at this is to look at your child and see, are the eyes level? When I'm looking at my child, are the eyes level, or is one eye higher than the other? Even a small fraction can make a big difference. That has an indication to say that there might be some cranial bone malalignments that can be corrected, by the way. These can be corrected. But if parents aren't really attuned to that, are the ears level? Does my child smile with one side of the face more than the other? Is the nose, the midline of the nose, is it lined up in the midline of the teeth between the two central incisors? Is the upper and lower teeth, are they in alignment? Is there crowding and crooked teeth going on with my child? All of these things, in the deciduous teeth, the baby teeth, are there spaces interproximally between each of these teeth? You should not have a child. If a child has very tight baby teeth where there's no interproximal space, where on earth are those great big permanent adult teeth? Where are they going to go? And so if the child has failed to develop their dental arches because they have just not had this full developmental thing, has the child got a tongue tie? The frenulum underneath that child's tongue should not be tight. That child should be able to get that tongue up and forward in the mouth. Did the child have trouble breastfeeding? Was the child able to latch, or did the child have trouble latching in the various early stages of life? So there are telltale signs that can be identified that parents need to kind of walk back through. And if your child's now 3 or 4 and you missed that stage, go back and think, was it a traumatic birth? Was there anything that happened during the pregnancy? Any trauma, any kind of nutritional deficiencies? Was the mother, did she have any dietary or nutritional challenges? And it's beyond folic acid, it's all kinds of things, but just to kind of walk back through to figure out, okay, were these things there? And is my child now potentially underdeveloped in terms of the craniofacial complex? Because it's a failure to launch is what it is. It's a failure to develop the cranial bones. There's 29 total bones in the cranium, including the ones in the inner ear. And so did those bones align the right way, or was there some trauma in the birth process, in the aftermath of that? Is everything symmetrical, and is the child's shoulders level, the posture of that child, is that all affected? These are things that the parents can observe and look at and consult with their pediatrician about, because all of those things I just mentioned have directly been correlated and linked to the presence of obstructive sleep apnea in a child.
Kirk, this is fascinating and so educating. You're like diving deep and giving parents and listeners out there some really like actionable items that they can take and work out if this could possibly be an issue. I will tell you, back in the day when my son was diagnosed, not once did I hear any of this. And so even when he had sleep apnea, even when he went for an operation to correct it, none of this was told to me. So I appreciate that you're out there, you're advocating for it, you're sharing this with my listeners, because this is exactly what we are all about. I'd love for you to go into a little bit of a bit deeper in your experience. Obviously, like something like this can lead to ADHD misdiagnosis. But what are some long-term sort of developmental risks of untreated pediatric sleep apnea?
Oh, wow. I'm so glad you asked that, because first of all, the condition typically will not go away on its own. And so the idea of watchful waiting, which is that's what the doctors talk about, right? If we just look, this is a phase, your child's going to go through this and blah, blah, blah. I've even seen orthodontists tell parents, you know what, that's just normal. Bring the kid back when they're, 10 or 11 years old. We'll put him in braces. We'll fix all that. Well, not so much. Not so much. In fact, there's a lot of evidence out there that suggests that putting a child in braces that already has some compromised developmental part going on with their oral cavity. I thought of one other thing I wanted to mention to see that parents can look at. I mentioned the lack of spacing between the teeth in the baby teeth. Also look to see if there's a narrow palatal vault. So a narrow palate. So the upper arch of the dentition, is there crowding or is it very narrow? Because if it's high and peaked, it's actually impinging upon the nasal cavity and crowding out the nasal ability to breathe. So some of the reasons why these children are breathing through their mouth is because their high peaked palate and narrow dental arches are pushing that tissue up. Remember, the roof of the mouth is the floor of the nasal cavity. And so if you've got a high peaked palate we want to have not a Gothic arch up there. We want to have a Roman arch.
Okay.
And have nice wide Roman arches in our upper palate. And the mandible, the lower jaw, will follow the maxilla, the upper jaw. So if the maxilla is underdeveloped and there's a narrow palate and a narrow dental arch with crowding or tight teeth, the position of the jaw, the lower jaw, the mandible, is going to be held back and retruded. Well, that just puts that tongue and everything back in the space behind it and compromises the airway. That's the airway, folks. It's what happens when the air enters the nostrils and goes back up in through the apertures and and then does a hard 90-degree turn south and goes back through that. If the tongue is back and the lower jaw is not pushed forward, that air, especially when a child tries to sleep, that airway remains just, and that prattling back and forth is where the snoring comes from and where these apnea events, where it actually just closes down. Okay.
Makes total sense. So
yeah.
Let's sort of dive into like long-term issues if we don't deal with it.
Okay. So yeah, that was my long answer to your question. I'm not sure I ever got there. Okay, so one of the things, there's a lady a researcher in New York at Yeshiva University. Her name is Karen Bonnick. Karen did one of the largest trials that has ever been done, 11,000 kids, and one of the things they determined was a compromise in IQ. Lower IQ for the children. Remember, these children are experiencing this at the most critical time of their lives developmentally, where they're going through those early toddler stages, those early growth stages, preschool stage, where all these craniofacial tissues and everything is needing to develop fully. And if they're denied that, their little minds, their brains are not able to keep up with everything that's coming at it. And so lower IQ, falling behind academically. We see kids who come from brilliant parents, right? So the gene pool is right, everything you'd want it to be. And the child that has obstructive sleep apnea is failing out or being held back in school, is a behavioral problem, can't concentrate or focus on their homework, can't stay seated long enough to do anything, the papers and stuff in school. And so what happens is that they almost become labeled as a child who's somehow not smart or somehow not capable. Another message I hope that your parents take away from this, your listeners, is that can all be reversed. It can all be reversed by correcting the developmental deficiencies that we're talking about here that manifest as obstructive sleep apnea. And so when you see these signs in your child, and your child's maybe, not at the top of their class where you expect them to be, it's not that child's fault. They've got a developmental deficiency going on that they neither are aware of nor can they control it. But when you correct those things, you can actually put that child on a fast track. And when I say that, I want to also note that there have been, and I could show you identical twins that are not identical. And one of the children was breastfed, but the other one had trouble latching on, and so the other one was bottle fed. And so what happens is that over the course of time, these two little boys, and I'm thinking of a particular case I can reference, but these two little boys develop very differently. When the breathing and airway problem was reversed, the child that was literally at age 9.5 was 4 inches shorter than his sibling. And these two remember, their genes are identical, right? They are identical twins. In 6 months' time, the child that had been deprived of all these things grew up to match and catch up with his brother, and caught up in school and caught up in every other way. So I want parents to really take hope away from this. People often ask me, what is Vivos sell and my company? And I tell them, more often than not, it's hope, right? It's you're running around, whether you're an adult or a parent with a child like this, and you're not getting answers, remember that your pediatrician or your general family physician got a total of 4 hours in an entire 4-year curriculum of medical school. They got a half a day where somebody gave them some lecture on sleep and breathing.
Kirk, you are preaching to the choir here. I say that a lot, actually, because it's like the pediatrician only got 1 hour of nutrition training in their whole degree. So I love that you actually brought that up, and I love that you're putting this out there and you're spreading the word, because that's everything that we do here on the Soaring Child Podcast and at the ADHD Thrive Institute, because kids with ADHD can thrive in life, and this is a perfect example of one of the things that can help them. I do want to say that I wish that this was part of every pediatric screening, just like some of the things that I talk about should be part of that screening at a young age as well. Let's talk solutions. What treatment options exist for a parent that the kid's diagnosed with sleep apnea? What are the treatment options out there? We know we've talked about the operation to take out the adenoids or the tonsils. Maybe some of the listeners have heard of CPAP, but what are those other alternate options for them?
Okay, so this is really important, and this is where parents need to step up and really be parents for their children, because the medical community does not have very good answers for that. They have tried CPAP on children. What did they find? That the CPAP, the pressures of the CPAP to seal that on their child's face, prevented those children from developing their cranium and their craniofacial complex. And so all they did was make the ultimate problem worse by putting it. So CPAP would be contraindicated for a child. All right. So that's number one. And by the way, just to make sure everybody's aware, I am not a dentist. I am not a physician. I am not a clinician. I just happen to have been involved in probably, I don't know how many thousands of these cases, and I've seen the end from the beginning of these cases, and I kind of know what happens. And so you asked about solutions. You need to guide the growth and development of this child. And so what our philosophy is that the worst thing you can do is to thwart that growth, that normal growth and development, what Mother Nature is trying to do by constricting that artificially. All right. So what we want to do is we want to find a way to non-surgically intervene and promote the growth and development. So if there's some epigenetic force that's not allowed that, so that could be a chemical, it could be a nutritional deficiency, it could be, as we said, some trauma during birth, it could be prenatal, it could be postnatal, but some type of a situation where that child is not thriving because they didn't develop their physical body the right way, especially their upper portion of their body, then that needs to be addressed. And how do we do that? There are appliances, oral appliances, that are relatively inexpensive, that will allow that child, we actually call them guided growth and develop appliances, that actually can promote the normal growth and development of the child. Now, the one benefit is that these children with crowded teeth, crooked teeth, malformed arches, cross bites, all these things, those can all be corrected from age 3, 4, 5, 6. And by the time a child gets to 8, 9, and 10, they don't even need braces. And about 90% of the time, they will not need braces. And the benefit is that they will have a big open patent airway. And that's the goal. The straight teeth is wonderful, and it's cosmetically very appealing and nice and all that. But remember, the functionality of that airway is central to that child's normal growth and development, both neurologically and physically.
Yeah, no. So I want to ask, obviously you're talking about the younger children, but we have a lot of listeners that have, 8, 9, 10, 11, up to, 18 years old. And so we can obviously correct it at the younger age. What happens with those kids that are older?
Well, we have to bring in the big guns to do a little bit more. The young children are so malleable and honestly, the young children are very compliant in wearing these things, right?
Mm-hmm.
So as you get older, you get less compliance and you have to do a little bit more to kind of get the kid directed in that. But we have the only FDA clearance in the world to treat children with an oral appliance device. So the FDA recognized that there is something in our technology that allows for the remediation of these conditions of OSA in children that are a little older and more advanced. So the actual clearance is for children ages 6 to 17.
Wow, awesome.
But our devices, it's actually it's a pediatric application using the same devices we use in adults. We just have to make them smaller. They're custom for each child or each adult. And so we just have to make them a little smaller and get that in there. But actually the outcome there is really good. We have great success with the older children, the teens and all that. So if you have a child in college that's falling asleep, if you have a child that's having, the excessive daytime drowsiness, maybe some snoring, maybe some, just lack of energy, that's another big sign in adults. As they get older, they'll go from hyperactivity to lethargy, right? They just become, I just don't have it in me anymore. I don't know what's wrong with me. I have brain fog. I can't think clearly. So if that's the condition, we've got to redevelop the architecture here of the airway. And that's really, we actually call it airway architecture to just sort of encapsulate what this is. We've got to rebuild the structures that allow for the airway. Remember that the human airway is not an organ, right? We have a heart, for example. That's an organ within us. But the airway is a functional space. And that functional space is defined in its perimeter by other tissues, including sometimes we often co-treat cases with chiropractors because the back wall of the throat is actually the pharyngeal wall back there is actually right behind that is C1, C2, and C3. So upper cervical chiropractors, we work heavily with them. So even in a pediatric sense, we can improve a child's breathing by about 30% just by going to the chiropractor and having them make certain corrections to an airway or a spinal column or the atlas, really, that is maybe subluxed and not in the right position. So there are a lot of times there are multiple disciplines in medicine that can be marshaled to be brought to bring to bear on this. But what we don't want to do, if we can help it, is constrain Mother Nature's desire to grow this big, wide face and smile and all that sort of thing. And we don't want to, if we can avoid the surgery, we have laser, for example. We have new technology out of Italy, of all places, that allows for swollen tonsils to be reduced down to normal overnight. Literally within 24 hours, you can take kissing tonsils and reduce them by 90% and avoid the surgery altogether. Latest technology, it's delivered typically by dentists. Some ENTs have picked up on it, but there are techniques and technologies today that can do this. And so there are better options and information today than ever before.
For sure. And I mean, the world is an exciting place. That's for sure. Curious, if you've got a child that's using this device, what does that process look like? How long are they using it for? I know it will probably differ, but what's the range of what does that treatment plan look like?
Well, the effects of these devices are almost immediate. The first thing that the parent will notice is that the child is sleeping more calmly, more deeply. The restless leg syndrome. A lot of times, children with this disorder, their bed sheets will be all over the floor in the morning, and the child will be, thrashing around. Right? That's the body trying to constantly adjust to keep that airway open. Okay, so they'll see that the child is sleeping more calmly. They'll see that the child is falling asleep and sleeping more deeply. They'll see the establishment of nasal breathing or the reestablishment of nasal breathing. the child will go from having nightmares to having sweet dreams. So night terrors is not normal. And so that's another sign of obstructive sleep apnea. So the restoration of normal dreaming, breathing, deep sleep, the nasal breathing we've talked about, and just a certain calmness will come over that child. The child will be more responsive to parental, commands and parental discipline and that sort of thing. The necessity to discipline the child will reduce because the child's not in a constant state of agitation. And so
what does the long-term treatment look of that? Is it, how long do they have to wear this device for? Is it lifelong?
No. With the children, the treatment in adults, it's about a year or less. Okay. And for probably kids in their late teens, right? It's a year or less, and it's in the evening only. And even with the children, we want them wearing it about an hour before bedtime, and we actually want them doing some masticatory exercises in that device, and then sleeping in it overnight. But then they go to school, they do all their things, and they live the normal life. But since the children are going through such phases of mixed dentition and the eruption of their permanent teeth, sometimes they'll need to be in an appliance for 2 or 3 years, right? Yep. Or maybe even sometimes 4 years. But an adult, it's about a year, 9 months to a year. But once it's done, it should be a lifetime of no further interactions, no further interventions, no CPAP as an adult, no all the stuff that goes along with that, right? So,
well, Kirk, you have opened our eyes today. Definitely, something that a lot of our listeners, including myself, have not gone this deep into this issue. And what you're doing is really changing the game, away from that traditional approach. And it's so aligned with everything that we talk about here in, really helping that child thrive. And there will be a couple of different things that will help them do that. But breathing is at the core of everything. Now, I ask every guest this: if you could share just one small actionable tip that parents can start using today, what would it be?
Well, I think the actionable thing would be get your child tested. If you make those observations, like I said, if you're looking at some of these key signals, these clues about obstructive sleep apnea, and you note a couple of these things, go find somebody that will test your child for obstructive sleep apnea. Now, there's a company called Sleep Image. They're also here in Colorado. That's where Vivos is. But Sleep Image has a little ring that a child wears on their finger, and you don't have to schlep your child down to the children's hospital and take an overnight sleep study. Yes. Oh my gosh, that is such a hassle, and there's a 6-month wait. So there are clinicians that use this FDA cleared sleep ring. It's for kids as young as 2. Wow. And so they have a ring. It just goes onto their finger. You bandage it up so they don't rip it off in the night, right? But that ring will automatically sync up to a cell phone. And then overnight, that test will be done. And you'll have, by 10 o'clock the next morning, you'll have a complete sleep test on your child from home, from their own bed, without having to go over to a sleep test. So I would say, as the number one action, if you as a parent suspect that your child might have this condition, get them tested. Find a doctor, find somebody that can test them. You don't have to wait 6 months to go to, somebody will be able to get that to you. Check the Vivos website, call us, and we'll find a clinician who has rings or has the ability to get your child tested. We'll get somebody on that case, but get your child tested. That's what I would say, because otherwise you're never going to know. You just don't know. You're just going to be in a world of limbo, not knowing for sure what's going on, and it doesn't go away on its own.
Mm-hmm. Kirk, wow. And I'm just going to say, this is an Australian thing, but there was this advertisement in Australia that was, if you never know, if you never go, you'll never know. So on that note, Kirk, thank you for shedding light on this incredibly important and so overlooked piece of the ADHD puzzle. Please tell listeners where they can find and follow you online.
Well, I think if they so online, I would say go to vivos.com. There is on Instagram, there is the Airway Queen, one of our leading doctors there, or the Airway Dentist. Those are a couple of different clinicians. One's in Houston, one's here in Colorado. And you can just find people that sort of treat their patients in this manner. There's also a group out there online called Tooth Pillow. They use Vivos appliances. So there's lots of ways to kind of start to get information about this, but get your child tested, and then the therapeutic options will become available.
Amazing. Thank you once again for joining us and just sharing this fantastic topic. Parents, if your child is still struggling despite every single thing that you've tried, this may be the missing link. Sleep quality matters just as much as nutrition, just as much as, or even more than sleep, behavioral strategies and academic support. If any part of this conversation resonated with you, I really encourage you to look more closely at your child's sleep, especially if you notice snoring or their mouth opening or restless sleep or constant fatigue. If you found this episode helpful, please share it with another parent or teacher or doctor or whoever. It could make all the difference for a child who has been misdiagnosed or misunderstood. And don't forget to subscribe to the podcast so you never miss more expert conversations just like this one. Listeners, thank you for tuning into this week's episode of The Soaring Child. I'm Dana Kate, your ADHD health practitioner. Keep on thriving. Thank you for listening to the Soaring Child podcast today. To learn more about how to help your child with ADHD soar using natural strategies, visit our website at adhdthriveinstitute.com and follow us on social media at ADHD Thrive Institute.